Hello everyone, my name is Geletaw Tessema, working in Ethiopia, Addis Ababa. Good morning, good afternoon, everywhere in the world with different time zone. First of all, I would like to say thank you, Science Fracture Care International, and I got smart course organizers for this good opportunity to give our experience, what is done in Ethiopia. Hope it will help for all of us in working in difficult situations. So my topic is on pelvic ring fixation in the absence of CR. So I will discuss on introduction, anatomy of the pelvis, bone model, and our hand. Pelvic ring injury, the mechanism is high energy, blunt trauma, and mortality is very high in acute settings, like 3 to 15%. If it is open, more than 50%. And unless they are treated properly, the mortality and morbidity is increased than the other fracture patterns. Hemorrhage is a leading cause, so I will not deal on how to tackle the emergency pelvic ring fixation. Rather, I will discuss on techniques in the OR in stabilized patients. So the difficulty in working in a resource limiter center is, the first thing is you are the only person looking at the patient, and the patient is begging for your help. In the absence of proper training and in the absence of appropriate material in the OR, that's very difficult. And you are you're teaching like don't do harm. Is it affect your psychology, and more it creates more anxiety on you. But there is a possibility to manage, even though you don't have a proper training and you don't have a proper CR in the OR. So the first thing what you have to have in the pelvis is you need to have a proper material, especially pelvic sets, because the pelvic is different. It's not like similar to fixation of the forearm or the tibia, because it is a three-dimensional structure. The neurovascular structure is at risk for injury. So you need to have a proper clamp, a proper soft tissue protectors. And another thing is anatomy. You have to know properly the anatomy, the arteries, veins, nerves, and how to tackle this and how to protect them during your surgery. So if you understand well this, the approach may not be difficult. So the approach may be discussed in a few minutes later. So the first thing what you have in the OR when you think of pelvic ring injury is bone saw bone model, sorry. So your saw bone model, I hope you will have a CT scan in every of your hospitals. So you have to reconstruct a 3D model of your CT scan so that you will have a good understanding. For this, I recommend you to have a free X-ray viewer. It's called Radiant viewer or DICOM. That will be a good thing for your pelvic fixations. So how to use a pelvic model? Once you reconstruct on your CT, then back to your model. So look at it in different direction. In which place should I put my retractor, and in what direction I put my screws? So that's very important. And you have to also call somebody, especially when you start, you may be confused inside. So that you can call your runner to bring the pelvic model inside the OR so that you can see where you are. So it will guide you easily. And it's also important to analyze after you finish your surgery, see the pelvic model again. Where was your screw? Where was your retractors? So that you will have a good understanding for future surgery too. So in the absence of the C-arm, your hand is very important. You have to coordinate your brain and your hand, and you have to look the pelvic model in mind. So your hand will help you as a guide. Sometimes it will help also to estimate the screw links, and it protects the soft tissue. So I will show you how to fix this type of fixations in the absence of the C-arm. So this is a Simpsons plating technique. So the first thing is you have to open your pelvis anteriorly so that you can put your Hohmann on each side of the pubic tubercle, and then you reduce your clamp. Once you reduce the clinically the anterior symphysis, the next step is plating. Plating, it could be by using symphysis plate if you have. If not, you can use a recon plates of 6 or 8, 7, 8 hole plates. So the thing is the way of your trajectory of screws. So you put your hand, look, my hand is just posterior to the pubic symphysis, so that I am palpating. First of all, I protect the bladder. You can apply, you can put also the malleable retractor, and you put your hand so that you can palpate the pelvis, so that you think you are drilling anterior to your hand, so that you are in a safe corridor, okay? So the pelvic pubic bone is like here anteriorly, it is a wider and thicker place. So aim to have a strong and longer screws. So the first drilling is like a bit deviated lateral and a bit anterior. There is some differences in male and female. In female, a bit the pubic rami, the body is a bit laterally projected, but in male a bit vertical, so that you palpate with your finger as far as you can reach, and you drill it in this fashion. That is the first one. The second screw, you may do a bit medial side, so that you can lock or recross your screws. So these two screws are, most of the time, it's more than 50 or 40 to 60, sometimes it may range to 70 3/5 screws. So the next, the other screws, it can be either in vertical or a bit deviated in order to have a long trajectory. The next one is SI plating. Sacroiliac fixation, ideally, it's good to use a SI screw that needs C-arm. So in this case, if you don't have C-arm, what you do is, the first thing, see your CT or X-ray whether there is a fracture on the ala of the sacrum or not. If there is a fracture, it's not a proper place to put the screws. So if it is intact, then the next step in your approach with lateral window, first find your SI joint, then you elevate the periosteum from the ala. So here you have to be cautious about it. You shouldn't damage the L5 nerve root. So you have to push all the way, the whole periosteum together. How much we have to go medial, like a finger breadth and a bit a centimeter for your Hohmann placement. Here, like if it is too much to the edge of the ala, you may not have a good purchase. So that at least you have to have a place for 1 screw, ideally 4/5 screw. If not, you can use 3/5 screws. And your Hohmann, when you put a bit medial to your place of the screw, and shouldn't be like aggressive, because you may break it the ala of the sacrum. The configuration, if you have only sacroiliac disruption here, you can use orthogonal plates, like 3-hole plates. Ideally, if you have like 1 hole allow 4/5 and the other 2 3/5 screws, that will be a wonderful one if you have. If not, you can use the recon plates. So the trajectory, the direction of the screw matters. Here, the foramen of the screw, on the model, what you see, there is foramens. So you shouldn't go to there, because that is a nerve root coming through. So the trajectory is like, as you see here, you can put 1 pin into the joint, just into the sacroiliac joint, so that it should be parallel and a bit anterior, because the sacrum is like deviated anterior posteriorly. So your hand, or the drill hand, is pushing the abdomen and a bit elevated, so that you can parallel with SI joint, so that you can safely put your screw directly there. The next one is LC2 screw, especially if you have a fracture on the iliac wing. You can use 2 screws, either plating on the edge of the ilium or on the superior suprapectinal region, or you can use screws into the directly from anterior inferior iliac spine to the posterior superior iliac spine. That is a good bone in that trajectory, and you can add more on the wing of the ilium, because the middle part is not a strong bone, so that you cannot fix there. So here, with your lateral window, you can put your malleable so that you can see directly the iliac fossa. Either you can start by reducing the fracture, or you can just start by drilling so that you can see directly when the drill is coming through the fracture site. If not, you can adjust. Once you see inside the fracture, you can reduce and you can advance proximally. The fixation of the edge of the ilium, most of the time it's good to start a bit posterior so that you can have a good trajectory, because the proximal one is iliac wing is curved one, so that in order to access that one, you have to be a bit posterior so that you can see directly and you can advance some of the screws. So let me discuss on some of my patients, in real patients. So this is a 32-year-old male patient who got road traffic accident, and as you see on the 3D recon by the DICOM, there is opening up of the symphysis pubis and cephalic migration and posterior displacement of the sacroiliac joint, so that my fixation, look, I use 145 screw on the ala of the sacrum and 2 screws on the ilium, and another recomplete on the anterior pelvic ring. The anterior pelvic ring, you see on the inlet view, there is some displacement that is acceptable in the absence of the CR. So when you have this type of fracture, first open your anterior pelvic ring and apply your clamp and go to your lateral window, see the SI joint, how it is reduced. And if it is reduced, you start your fixation either from posterior or anterior. If it is not reduced, you can negotiate a bit correction of the displacement. As you see here, the screw, the first screw trajected laterally and the other one is a bit medial, so that you will have a good fixation, and the sacral screw is just parallel to the SI joint. The next one, 45-year-old male patient. He is also with a road traffic accident. He has pelvic ring fixation on 2 sites. One is a lower crescent fracture, and the other is the opening of the symphysis pubis. So here, all the same technique, just you reduce anterior one, apply your clamp, and go the lateral window. Either use, as I said before, 2 parallel screws on the edge and on the LC2 screw. But here, there is also another fracture exiting on the edge, so that I prefer longer plates holding the whole edge of the ilium, starting from the anterior inferior iliac spine towards the posterior superior inferior iliac spine. And the other plate is on the suprapectineal area. Here, you don't need to go to the SI joint, because you have some intact ilium, so that you can connect with the fractured ilium to the intact one. So the fixation is well, and the screws is crossing. That is wonderful for stability purposes, and the fracture healed without any problem. The other one, a 34-year-old male patient with road traffic accident again. This is also crescent fracture dislocation with pubic rami fracture. Here, like, you can use, like, as I said before, the screw, but for the screw fixation, the intact part is not strong, so that will not be ideal one. So this patient also, as you see here, on the edge of the ala of the sacrum, there is a fracture. So that's very difficult to put a screw or a plate on the ala of the screw. So I use one plate on the edge of the ilium, and the other one just on the intact part of the ilium, not on the sacrum, because the sacrum is broken here. And the other fracture fixation by the suprapectineal plates. So here, one of the screw is beyond the unaffected symphysis pubis, but if you don't have the C-arm, that will happen, no problem. But the fracture healed in a good position. The next one, 18-year-old female young patient. Here, like, there is also zone to sacral fracture. If you have this type of fracture, SI screw is very important. If not, you have to use posterior sacral fixation. personally, I don't want to use posterior fixation. Even for beginners, it is not a good one because soft tissue complication is very high in a patient to have the windmill days. So what I prefer is just, this is quadrirami with the fragments are going into the pelvis. So for future delivery process may not be a good one. So I prefer to use plates all the way from right root of the acetabulum pubic rami to the left side. It may need a larger approach. You have to flex both hips in order to avoid struggle with the iliopsoas muscle, but still it is doable to fix, and you allow not to wait with the patient for 3 months, so the fracture heal in these positions. The other patient, she's 15 years old female patient also. As you see here on the iliac x-rays, the pubic anteriorly pubic rami is broken, and posteriorly the sacroiliac disruption, but the sacral ala looks good. So look, this is my trajectory. As you see here, the screw is just parallel to the SI joint, and I augment with 2 screws on the iliac wing so that it will be stable. Anteriorly, it's possible to apply X-fix, but most of the time patients are not tolerating, especially in third world. Patient may not be comfortable to also to take care of the pin side, so that may be infected. So most of the time I avoid not to use external fixators, but the fracture heal in a good position. The other one, this is a patient who have a wall fall on the pelvis, and see the 3D recon. There is a lock symphysis with pubic rami fracture and crescent fracture dislocation. So it's possible to use this one also with previous technique which I said to you, symphysis pubis plating, and then another 2 screws on the ilium. As you see here, like the 2 pubic ramis are not fixed. So if you want to fix this one, you have to advance your plate all the way up. But it's not a must to fix always the pubic rami, because as you see, the right hemipelvis is almost well constructed posteriorly, and the pubic rami is intact, so that it will control the movements. So I have many patients with this type of fixation, and they do well. The pubic rami may not displace, because posteriorly on the left side, the SI is intact, so there is no possibility to displace this fracture. So my summary, like understanding the anatomy of the pelvis is very important. And if you are comfortable with the approach, the fixation technique may not be as such difficult, even though you don't have appropriate CR in the OR. And the next thing is the pelvic model is very important during planning, during your surgery, and after the surgery for summarization, what was going on in the OR, what was the challenge, and what should be corrected in the next surgery. And the third one, very important, was in coordination of your brain with this hand and with your model. In what direction is the bone stock is there? So how I advance the screws. So this is very important technique. Okay, thank you very much for your listening for my talk. Hope it will be helpful for your day-to-day practice. And again, I would like to thank both the organizers. Thank you very much.